Welcome to one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 19th episode of Optometry series. First of all, I would like to introduce my teammates with you all. I'm very happy to welcome Ms. Anshika ma'am. Hi ma'am. And I'm very happy to welcome Ms. Meenakshi and Ms. Jemima ma'am also joined us today. Welcome both of you. So the topic for today is electrodiagnostics. And I would like to ask Anshika ma'am, so who's our moderator today? For sure, you must have brought some eminent people. So please let us know about the moderator and panelists today, ma'am.
Thank you so much, Gomati. I heartily welcome, with all my whole heart, welcome Kiran ma'am and Aarthy for today's session. We were actually waiting to, get hold of their dates so that their availability, so that we could have this particular session with them. Kiran ma'am has been in electrodiagnostics in clinicals for, I think, around 25 years, ma'am, 25 years. So I think she would have been the apt person to really teach us about ERG and VEP. And Aarthy, she's practicing at Jipmar Pondicherry. Right now, she's doing ERG and VEP and EOG. So definitely these two people are would be really great to teach our students and all our YouTube audience about the importance of electrodiagnostics, how optometrists play a role, and what are the diseases that we can pick up with ERG. So thank you, Kiran ma'am, and thank you, Aarthy, so much for making time available today and giving us your time to let us understand how ERG and electrodiagnostics works. Thank you so much. Over to you, Gomati.
Thank you so much, Anshi ma'am. So once again, welcome Kiran ma'am and Aarthy ma'am today. So thank you so much for joining us, ma'am.
It's a pleasure to be here with the Agarwal family. So we can carry on with the session.
Sure.
Aarthy.
Yes, ma'am. I'm fine with it.
So I'd like to welcome the MC of today, Ms. Priya. So Priya is here as a presenter today. And I would also like to welcome Ms. Kavya. So Kavya is the MC today. Yes, Kavya, we would like to know more about our panelist and moderator from you.
Good evening, one and all. I'm Kavya, studying second year at Dr. Agarwal Institute of Optometry. It is a great honor and privilege for me to introduce Ms. Kiran Kumari ma'am and Ms. Aarthy ma'am. Ms. Kiran Kumari ma'am has completed her master's in optometry at Elite School of Optometry. She harbored a deep passion for training next generation of optometrists, which leads to become a national faculty which specialized in advanced diagnostic and clinical application. Her 25 years of experience in healthcare academic research made her a fabulous clinical instructor. Her travel towards shaping the future of optometrists doesn't end an instructor, but also made her to do many fascinating stuff such as specialization at biomedics, optotechnic, visual electrophysiology at ocular biometry. Once again, I'm glad to invite her for this session as panelist. Next, I like to initiate Ms. Aarthy ma'am, an optometrist at Jawaharlal Institute of Postgraduate Medical Education and Research in Puducherry. She has completed her bachelor's at Institute of Ophthalmology, Joseph Eye Hospital, Trichy. Has the best outgoing student, her love towards her juvenile composed her draw up pediatric fellowship to her optometrist, leaving no stone unturned in her pursuit of intelligence. Ms. Aarthy ma'am entered at Elite School of Optometry. She completed her master's. She was associated with Medical Research Foundation at Shankara Nethralaya, Chennai as a pediatric optometrist. For a period of 6 years, as a superlative optometrist, she had clinical experience about 10 years. In pediatric optometry and binocular vision, her proficiency in diagnostic techniques such as electrophysiology, OCT, has above 7 years of teaching experience. She has scientific publication and co-author a book chapter and is a part of ongoing research project at our institute. Her area of an interest include optometry, education, pediatric optometry, electrodiagnostic, CVI, and community optometry. Ladies and gentlemen, please join me in extending a warm and enthusiastic welcome to our chief guest, Ms. Kiran Kumari ma'am and Ms. Aarthy ma'am. Thank you so much for this Thank you so much for accepting our visit to moderator and panelist today's session. The presenter for today is Miss Priyadharshini, studying third year at Dr. Agarwal Institute of Optometry. Miss Priyadharshini, you can start your presentation.
Priya, unmute Priya. Thank you, Kavya. Good evening, everyone. This is Priya from third year. Start the presentation. Sure. Topic for today's session is electrodiagnostics. Firstly, what is electrodiagnostics? Electrophysiology testing includes a battery of tests which can be used to provide information about the visual system beyond the standard clinical examination of the eye. The primary objective of the electrophysiologic examination is to access the function of the visual pathway from the photoreceptors of the retina to the visual cortex of the brain. These tests check how your eyes and brain process what you are seeing by measuring the electrical activity in your retina and optic nerves. Coming to the uses, electrophysiologic testing is useful in diagnosing a variety of inherited retinal optic nerve diseases, which includes toxic drug exposure, inflammatory conditions, intraocular foreign bodies, retinal vascular occlusions, genetic condition, retinitis pigmentosa, achromatopsia. Types. Electrodiagnostics is majorly of three types. One is visually evoked potential, electroretinogram, and electrooculogram. For today's session, we are only going to focus on visually evoked potential and electroretinogram. Visually evoked potential. When light falls on the retina, a series of nerve impulses in the form of When light falls on the retina, a series of nerve impulses in the form of electrical changes are generated and passed on to the visual cortex via the visual pathway. The electrical potential changes produced in the visual cortex by these impulses can be recorded by electroencephalography technique and is known as the visual evoked potential. Thus, VEP is nothing but the electroencephalography records taken from the occipital lobe, that is visual cortex. Uses of VEP. Visual evoked potential test can help diagnose multiple sclerosis, which often cause optic neuritis, a glioma on your optic nerve, usually due to neurofibromatosis type 1, compression of your optic pathways, such as from hydrocephalus or pituitary adenoma, visual pathway damage related to head or brain tumor, trauma, toxic optic neuropathy, other types of optic neuropathy such as anterior ischemic optic neuropathy, visual pathway issues due to infection such as meningeal tuberculosis. Indications of VEP. The most common indication, optic nerve atrophy, ischemic optic neuropathy, retrobulbar optic neuropathy, intracranial injury, optic nerve glioma, unidentified vision loss, optic nerve drusen, pale disc. Procedure. How is VEP done? This procedure is very safe and non-invasive. Firstly, some wires will be glued on top of your head to detect the brain waves. Each eye will be tested separately. Good cooperation needed. Patient will be asked to look at the screen similar to the television screen, with various visual patterns. Readings will be recorded through the wires on top of your head. After the procedure, the glues and wires are removed from your head. Usually the procedure takes about 45 minutes. Types of VEP. VEP is broadly of three types. One is multifocal VEP, transient VEP, steady state VEP. Transient VEP is furtherly divided into pattern reversal VEP, pattern onset and offset, and flash VEP. Multifocal VEP. Electrophysiological test that provides local VEP response from the visual field. Multiple individual VEP responses are generated simultaneously from 60 or so regions of the central 20 to 25 degree radius of the visual field. From a single continuous electroencephalography signal, a sophisticated mathematical algorithm extracts the VEP response generated by each of the independent regions. Coming to the uses, multifocal VEP is used to access local defects in the visual field, ruling out non-organic visual loss, diagnosing and following patients with optic neuritis, multiple sclerosis, evaluating patients with unreliable and questionable HVF, and following disease progression. To detect small abnormalities in visual signal transmission from centric and eccentric field. Response of multifocal VEP. Multifocal VEP response bears a superficial resemblance to the pattern reversal VEP. In the responses from the lower field, there is an initial negative component C1 around 65 milliseconds, followed by a prominent positive component C2 around 95 milliseconds, analogous to the N5 and P100 of pattern VEP. The second type, transient pattern reversal VEP. VEP is elicited in this. VEP is elicited by a checkerboard-like stimulus of alternating black and white square checks that reverse in a regular phase frequency. Waveform consists of N75, P100, and N135 peaks. P100 is usually a prominent peak that used for analysis. P100 shows relatively little variation between subjects, minimal within subject intraocular difference, and minimal variation with the repeated measurement over time. Second type of transient VEP, onset and offset. In this, VEPs are elicited by checkerboard pattern abruptly exchanged with a diffuse gray background. This stimulus is best suited for the detection, confirmation of malignary and for use in patients with nystagmus. This is the third type of transient. In this, VEP is elicited by a flash stimulus. This is useful to test uncooperative children, poor fixation due to poor visual acuity, and when optical factors such as media opacities prevent the valid use of pattern stimuli. And the third major type, steady state. This VEP is useful for visual acuity, especially for infants. Patients are presented with 10 to 20 pattern reversal stimuli ranging from coarse to fine in rapid succession during a 10-second test period.
Okay.
Over to the moderator.
Thank you, Priya. Now I request Ms. Aarthy ma'am to start with the report interpretation, ma'am.
Thank you very much. Is it audible?
Yes, ma'am, you're audible. It's clear.
Okay. I would like to thank Agarwal Institute of Optometry for giving us opportunity to be the part of the optometry series. Priya had explained it very well, so I would like to add few points here and there to make it a complete VEP. So as we all know that VEP is a diagnostic test which will allow us to assess the integrity of the visual pathway. Here, the electrical signals are generated from the visual cortex with the help of a stimuli that is shown onto the retina. It can either be a flash stimuli or a pattern stimuli. So where does the VEP response arise from? So they are believed to be generated from striate occipital cortex, N1 and N75 from visual cortex, P1, P100 from extrastriate cortex of the middle occipital gyrus, N2 and N135 from parietal lobe. She had briefed about the indications of VEP. So here pattern reversal VEP is done when there is unexplained visual loss, retrobulbar neuritis. It also helps in detecting multiple sclerosis, in identifying hereditary, metabolic and toxic optic neuropathies, and also in suspected intracranial lesions. Flash VEP is done when there is an opaque media or history of trauma, and when there is an infant with questionable vision in case of toxic and nutritional eye disease. And it is used as a tool for surgical monitoring during intraorbital or brain surgeries. Pattern onset offset is done in malingering patients and patients with nystagmus. So where do we place the electrodes? She was explaining the procedure. Let me explain in detail so that the students will get to know where to place the electrodes correctly. We usually use skin electrodes, which can be standard silver electrodes, skin electrodes, or gold cup electrodes. We usually use gold cup electrodes in our setup. They are placed in based upon international 1020 system. Here, when the active electrode is placed 10% above the anion, here the active electrode is placed. Reference electrode is placed 30% above the nasion, and the ground electrode is placed at vertex, mastoid, or at the earlobe. The components of VEP, you have ISF standards that has been given by ISCEV guidelines, so that we can use standard stimuli and parameters which can be used across the laboratories. So we have flash stimulus, which is a brief flash which is elicited from handheld baby flash or a big GANS field. You also have a pattern onset offset stimulus, which is generated from a monitor. This generates cortical responses to the change in the luminance in the visual field. You also have pattern reversal stimuli. You have 1 degree large check stimulus, which will elicit more of a parafoveal response, and 0.25 checks, which will elicit more of a foveal response. We follow, everybody follows IEV standards for recording VEP. So you have 3 protocols where the VEP can be run, where can be conducted. So every clinical lab should practice doing 1 or more protocols to have a reliable and reproducible VEP recording. So this is a short summary of what she had explained. This is how you will place the electrode in pattern. In all the VEPs, the electrode placement is same. In pattern VEP, the stimulus is elicited from a monitor. In flash VEP, you have a GANS field bowl. In baby flash, you have a handheld baby flash. After connecting the electrodes, you should check for the impedance, and impedance value should be checked between active to ground electrode, reference to ground electrode, which is connected to the channel, and both the values should be less than 5 kilo ohms, which is very important. And both the electrodes should have similar values, so that it will help you in recording a good VEP. And the requirements are like the distance has to be appropriately adjusted with normal room illumination with correction in place. One eye to be covered at a time, and impedance should be less than 5 kilo ohms. So in pattern VEP, we show high contrast black and white checker stimuli is used. You have 2 types of stimuli, which is pattern stimuli and pattern onset offset stimuli. In pattern stimuli, as Priya has explained, you will be showing equal number of black and white checkerboard on the screen, which will reverse abruptly. And we all know that pattern VEP is a consistent form of VEP, and it is more reliable when compared with other forms of stimuli. So here we have, how do we interpret the wave? We have a negative peak at 75 milliseconds, which is N75. We have a positive peak at 100 milliseconds, which is P100. We have a negative peak at 135 milliseconds, which is N135. This is how a typical pattern wave will be there. And moving on to the pattern onset offset VEP, here the pattern onset offset VEP, the checkerboard stimulus is abruptly exchanged with a diffuse background, and this is shown on a monitor. In this, you have a typical waveform at 75 milliseconds, which is C1, at 125 milliseconds, which is C2, at 150 milliseconds, which is C3. In flash VEP, which is elicited from a GANS field bowl or a baby flash, you will have a wave pattern like this, which shows N1, P1, N2, P2, N3, and P3. Here, you're supposed to concentrate on the P2 peak time instead of the N1 and P1. The important thing is to concentrate on P2 peak time. As you all know that flash VEP is pattern VEP is a reliable and consistent form when compared with flash VEP, because during flash VEP you have inter-subject variability, and it is also important for you to compare between the eyes, and the difference should be less than 10% when you're reporting VEP. So before reading into the reports, we should understand few terminologies. What is amplitude of VEP? Amplitude is nothing but the height of the potential P100 wave. This height from N75, the negative wave to positive wave. This P100 peak, which is measured in microvolts, is called as amplitude of VEP. What is latency? Latency is nothing but the time from the stimulus onset to the peak of the response. Peak of the response, which is measured in milliseconds, that is latency of VEP. So when we are reading the reports, we will be speaking about amplitude and latency. Amplitude is nothing but the height of potential P100 wave. Latency is nothing but from the time of onset to the peak of P100. When both are absent, it is said to be unrecordable waveform. So we all know that amplitude usually translates to the amount of axons conducting along the visual pathway, and latency usually translates to the myelin states of the visual pathway. So when there is reduced amplitude and reduced latency, or prolonged amplitude and latency, we are supposed to correlate with this. So before reading the reports, we should understand the factors affecting VEP, which is uncorrected refractive error and improper electrode placement, which will lead to noise when the patient is frequently blinking or during the test, or when the patient is tired, inattentive. And usually the VEP is done without anesthesia. In case if you're doing with anesthesia, the drugs are said to produce delay in amplitude and latency. Even the pedicloral syrup that we give will delay the amplitude and latency. Moving on to the measurement and reporting, we should have a similar VEP waveform across the laboratories, so that, and we should establish a normative value for every lab. And we all know that adult normative data cannot be compared with the pediatric populations. And whenever you are comparing a report, it is very important for you to do interocular comparison. So which will increase the sensitivity of the report. And while reporting, the report should have at least 2 recordings of every VEP condition. And there should be a report on stimulus, pattern, filter setting, and electrode placement. And the most reliable thing to look upon is the time to peak, because it is a useful clinical measure for every VEP reporting. So with this as basic knowledge, we will go on to case 1, who is 16 years old boy presented to emergency service of JIPMER on May 2021 with the complaints of headache for the past 3 days. And there was sudden gross decreased vision in the left eye, and there were no similar episodes before. And he was giving a history of COVID some 11 days back. On examining, his vision in the right eye was 6/9 and vision in the left eye was no PL. Color vision, contrast, pupil reevaluation were within normal limits in the right eye, whereas it was unrecordable in left eye. There were grade 2 RAPD in left eye. On fundus examination, right eye was within normal limits. Left eye showed disc hyperemia with blurred margins. On that visit, we couldn't do VEP because he was just 11 days after COVID. So we didn't want to have long exposure with him. So we didn't do him. When he came on 15th May for the second visit, his vision has improved significantly from no PL to 680. When the VEP was done, here the VEP showed marked delay. It shows us 120 milliseconds. The normative value of P100 is 100 milliseconds plus or minus 10. So this is 120 milliseconds, which showed marked delay, and the amplitude was also reduced, which is suggestive of optic neuritis. Again, when he came in the month of November, we had repeated the VEP once again, and his vision was improved to 6/6 by November. Though the vision has improved, the latency, there was marked delay in P100 latency, and the amplitudes were moderately reduced. Though the amplitudes have recovered, it has not normalized, which is suggestive of optic neuritis again. Moving on to the case 2, this is 46 years old male with complaints of blurred vision for the past 4 days, no complaints of pain and headache. And there was history of diabetes mellitus for the past 1 year. His BCVA being 6/60 less than N36 in the left eye. Fundus showed disc edema in both eyes. Fields, there was general reduction of sensitivity, and OCT showed diffuse edema in all the quadrants. Pattern VEP was done on him, which showed there was, though the P100 latency was delayed, the amplitude was also grossly reduced, which was suggestive of non-arthritic AIOA. And this is case 3. This is 22 years old female who presented to the clinic with the complaints of blurred vision for the past 10 days with no history of headache, weakness, and no similar complaints in the past. On examining, her BCVA was 6/9 N6 in the right eye, 6/12 N6 effort in the left eye. Color vision was normal in the both eyes. Contrast was reduced in the left, whereas it was normal in the right. Pupillary evaluation was sluggish, and grade 1 RAPD was shown in the left eye. And on further examining, her fundus revealed disc hyperemia with blurred margins, suggestive of papillitis. So here on doing pattern VEP, her P100 latency was prolonged, though the amplitudes were normal. She was diagnosed to have atypical neuritis. So after a follow-up of 1 month following ONTT protocol, her BCVA had improved to 6/6 in both the eyes. Color vision and contrast were also normal. Though the patient had improved to 6/6 and everything was normal, there was prolonged latency of P100 and the amplitudes have recovered. So with this, we are finishing. To summarize, the clinical significance of VEP, when there is delay in P100 latency, which is suggestive of demyelinating disease, such as optic neuritis, disseminated sclerosis, neuromyelitis optica. Reduced amplitude will be seen in ischemic optic neuropathy, AION, Leber's hereditary optic atrophy, where both P100 latency and amplitudes are affected when there is a compressive disease, which means both nerve sheath and auxiliary fibers are affected. So, take-home messages: when ERG is normal, VEP is abnormal, disease is located in visual pathway. When VEP is more abnormal than ERG, here both are abnormal, but VEP is more abnormal than ERG, which means both retina and optic nerve, both are involved. So with this, I would like to hope students will be benefiting out of this talk.
Thank you so much.
Thank you so much.
It was a very detailed explanation, and more than the interpretation, you added case reports with that. So I feel definitely the students would have been benefited with this, ma'am.
Okay, thank you very much.
Thank you, ma'am. Now I request Priya to start on ERG.
Thank you, ma'am.
Yes, Priya, continue.
Getting into electroretinogram, ERG is the corneal measure of an action potential produced by the retina when it is stimulated by light of adequate intensity. It is the composite of electrical activity from the photoreceptors, Muller cells, and RPE. This test will detect whether there are retinal problems in either dark or light conditions. Electrodes used in ERG: ground electrode, which is placed in forehead; reference electrode, which is placed in outer canthus; active electrode, which is placed in cornea. Active electrode is of two types: contact lens electrode, non-contact lens electrode. In contact lens electrode, one is Bullion-Allen electrode. This is bipolar reusable contact lens electrode with built-in lid speculum and lead wire. They are available in number of sizes. We use these electrodes mainly on sedated patients. Second one is jet electrode. This is unipolar, disposable electrode. The contact lens with gold-plated plastic material at the circumference acts as the active electrode. Non-contact lens electrode are of two types: Dawson Trick Litzkau plus electrodes, or disposable monopolar silver nylon thread electrode with adhesive fasteners. This is our main electrode, and the other non-contact lens electrodes are HK loop and gold foil. Procedure of ERG. The patient will be asked to lie down or sit in a comfortable position. Dilation will be done. Topical anesthesia is given and electrodes are placed on the cornea. Then a device known as retractor is used to hold open lids. This will enable them to carefully place a small electrode on each eye. One type of electrode is about the size of a contact lens, and another type is a fine thread placed on the cornea, which is a non-contact lens electrode. Another electrode is placed on the skin so that it functions as a ground for the faint electrical signals made by the retina. Depending on what the examiner is looking for, they may only place electrode on the skin around the eye instead of in the eye. Then patient will watch a flashing light. The test will be done in normal light and in a darkened room. The electrode enables the examiner to measure the patient retina's electrical response to light. The responses recorded in a light room will mainly be from the retina's cones. The responses recorded in a darkened room will mainly be from the retina's rods. The information from the electrode transfers to a monitor. The monitor displays and records the information. Which appears as A waves and B waves. Coming to the types, ERG is broadly of three major types. One is multifocal ERG, full field ERG, pattern ERG. Full field ERG is furtherly divided into scotopic, in which we reach the cones to detect the rod responses, and the second one is photopic. This will stimulate the cone response. Standard full field ERG. The full field ERG, also referred to as the standard or flash ERG, retinal potential elicited by a brief flash of light, recommended to be about 5 milliseconds in duration, that evenly illuminates the entire retina. Represents the summed activity of the retina and responds to a light flash. Dominated by extramacular rods and cones, it is most useful in patients suspected of having widespread retinal disease. Essential in diagnosis of numerous disorders including cone dystrophy, retinoschisis, congenital stationary night blindness, Leber congenital amaurosis, rod monochromatism, and paraneoplastic retinopathies. Waveform and components of full field. Implicit time is equal to time from stimulus until peak of activity. Amplitude is the voltage magnitude at peak of activity. A typical response to white light contains an early corneal negative component, a slower corneal positive component. ERG responds to various retinal cells. A wave is known to be generated within the photoreceptor layer and directly reflects photoreceptor activity. B wave is generated at the level of the inner nuclear layer, probably by Muller cells, and indirectly reflects bipolar cell activity. Oscillatory potential are thought to reflect activity initiated by amacrine cells in the inner retina. The second type, pattern ERG. In this, retinal response evoked by viewing a pattern stimulation, usually black and checkerboard are bar greetings, provide information of the retinal ganglion cell function and function of macula. Clinically, the pattern ERG can be used in a patient with an abnormal visual evoked potential to establish whether a retinal disorder is present, and thus differentiate between macular and optic nerve dysfunction as a cause for the visually evoked potential abnormality. It can also directly demonstrate retinal ganglion cell dysfunction. Waveform of pattern ERG. N35 small negative peak at 35 millisecond, P50 large positive peak at 45 to 16 millisecond, produced by retinal ganglion cells and other retinal cellular elements. N95 large negative peak at 90 to 100 millisecond, predominantly by retinal ganglion cells. The third type, multifocal ERG. This is a method of recording local electrophysiological responses from different regions of the retina. Provides a topographic measure of light-adapted retinal electrophysiological activity. Retina is stimulated with an array of hexagonal elements, typically 61 or 103, occasionally 241, each of which has a 50% of chance of being illuminated every time the frame changes. Each hexagon goes through a pseudo-random sequence, the M sequence of black and white presentation and has the probability of 0.5 of reversing on any frame change. By correlating the continuous ERG signal with the sequence of on and off phases of each element, the local ERG signal is calculated. Multifocal ERGs are a mathematical extraction of the signal and are not direct electrical potential from local regions of retina. The waveform of the local multifocal ERG response can be influenced both by preceding subsequent stimuli, the response to light scattered on other retinal area, quality of fixation. Indications of ERG are aid to diagnosis in patients suspected of having stationary or progressive inherited retinal degeneration, to access patients with retinal toxicity due to metallosis, retinotoxic or neurotoxic medications, patients with OHT glaucoma, documenting therapeutic effects of surgery or medication. Now let's see the interpretation. Over to the moderator.
Thank you so much, Priya. I request Kiran ma'am to start with your ERG interpretations, ma'am.
Thank you. I once again thank the whole Agarwal family to give me an opportunity. Are my slides visible?
Yes, ma'am, it's visible.
Just a moment. One minute. Yeah. So thank you, Priya, for the detailed explanation of the VEP and ERG. Thank you, Aarthy, for the VEP summary. So we all know that the electrodiagnostic test allows the examination of the visual system. Why is it more important to do electrodiagnostic system is they provided us with the objective information. There are few subjective tests which we do in our clinic, like the visual acuity, the visual fields. They also give us information of the visual pathway and the vision of the patient. But they are influenced by the subject's, what we can say, the information the subject gives us. Okay. Visual field test, when you do, the patient is unable to understand the test, and if the patient is unable, is fatigued, the response of the test can vary. Okay. But here in electrodiagnostic test, they are not influenced by the subject. So you get 100% correct responses or true responses from the eye. So the commonly used diagnostic tests which we do in our clinics are full field ERG, pattern ERG, multifocal ERG, and in VEP, flash VEP, pattern VEP, and EOG. So why are they used? They are used in diagnostic purpose of a disease, monitoring a disease, and it can also be used as a research tool. Okay. So what are the common conditions in which you would do electrodiagnostics? As told by Priya, she explained that we can do it for the hereditary and the congenital diseases and rule out diseases of the photoreceptors like the retinitis pigmentosa, cone dystrophies, and Stargardt disease. We can also understand the visual prognosis in cases of vascular disorders like the central retinal vein occlusion and artery occlusion, and see if what is the damage which has happened in the retina and the ischemia developed due to that. Okay. We can also assess the function of the retina, whether the retina is functioning or not. We can, if we are able to get a wave pattern in patients with near total cataract or with vitreous hemorrhage, it gives us an indication whether we can go ahead and do some procedure to enhance their vision. So the commonly used electrophysiological tests for the ocular diseases are, so if I find a patient with say opacity, corneal opacity or opacity due to cataract, then you can run a flash VEP and a full field ERG to understand the visual pathway and a full retinal evaluation to see the integrated responses from the photoreceptors. If a patient has, say, a diffuse retinal degeneration, then we can go ahead and do a full field ERG to understand the amount of damage which is there because of the pathology. If a patient has only maculopathy, okay, so where the central 20% of the retina only is involved in the disease. Say if a patient has a ARMD, wet ARMD, or only a central lesion, then I would be more interested in doing a local or multifocal ERG as suggested by Priya to understand the cone responses within the 30 to 40 degrees. Okay, because the full field ERG gives me information when most of my photoreceptors are damaged, I will be able to understand it. But if only the macula is affected, my full-field ERG will be normal. Okay. So for a particular macular problem where the patient has a pathology, I will do a multifocal ERG. She also specified that in patients with drug toxicity, we do ERG. Yes. In cases with drug-induced maculopathy or toxicity, we do ERG as a screening tool itself. We first run a full-field ERG, then we run a multifocal ERG to document the cone responses from the central 10 degree of the retina. Okay. In patients with optic neuropathy, we go ahead and do a VEP and understand the visual pathway. Okay. So the common indications would be inherited retinal diseases like the heredomacular degeneration, retinitis pigmentosa, and a congenital stationary night blindness, which is a stationary night blindness condition. We can differentiate with ERG whether the patient has a stationary night blindness or a progressive night blindness. Okay. Usually a progressive night blindness is seen in cases with retinitis pigmentosa, whereas the name suggests congenital stationary night blindness is a stationary condition and it does not progress. In patients with acquired retinal degenerations also, you can do ERGs and understand whether they are progressing or not. In patients with unexplained visual loss, where you don't know the cause why the vision is reduced, like the optic neuritis and the retrobulbar neuritis, which was presented by Ms. Aarthy. Okay. So as I told you, in vascular diseases where you're dealing with occlusions, to understand the amount of ischemia which has happened, you can run an ERG and see the whether the patient will go into an ischemic type or a non-ischemic type. Okay, because the treatment varies once the ischemic type CRVO is there. And in children where you are not able to assess the vision, you need information to understand how much of visual potential is there in the eye. You can run an ERG and VP to understand it. In toxic and nutritional eye disease also, you can use the ERG. So this is a chart which you can have it in your clinics, which is given by the International Society of the Clinical Electrophysiology of Vision, which gives you an overview of the complete tests which need to be done in cases of the common indicated diseases like the hereditary retinal disorders, vascular diseases. So it is not required that you just do one examination or one electrodiagnostic test. Okay, for a patient, the same patient, say for an hereditary retinal dystrophy, like a Best's disease, you may have to do a full-field ERG, a pattern ERG, and an EOG to come to your diagnosis. Okay, so you can run more than one electrodiagnostic test in the clinic to have a confirmatory report. So what are the anatomical generators of these signals? So the ERG signals and the multifocal ERG signals come from your photoreceptors and your bipolar cells. The EOG signal comes from the retinal pigment epithelium. Okay. And the ganglion cells contribute to your pattern ERG and photonegative responses. And the VPs, the ganglion cell axons, which contact the information, are the major contributors of the responses. And one thing we need to understand is your health of your photoreceptor is very important, because if the signal is generated over there, then only a ERG signal can be sent. Okay, so if your cones are responding well, then you have this multifocal ERG which is generated. Thereby you have a information which passed to the ganglion cells, and thereby a VEP is generated. So all of this is interrelated. So we need to understand that the photoreceptor health and the health of the retinal pigment epithelium is very important for all these signals to be generated and sent to the visual cortex, thereby get it recorded. Okay, so this clearly explains that from the visual cortex, You can record the visual evoked potential. You can record your multifocal VEPs and your sweep VEPs. And you have this information of the ganglion cell coming from the for the VEPs and the PHNRs. So first thing is you should have a very good electrodiagnostic lab. So today, the topic of the class was instrumentation and interpretation. Instrumentation, especially for electrodiagnostic, is very important because if the room is not correctly designed, you will end up in missing out on the signals of the retina, because these signals are very small. Okay, and these signals need to be amplified before they are recorded. So to set up an electrodiagnostic lab, there are few checklists which is to be followed. You need to have a spacious room with an area for dark adaptation. You should have an electrodiagnostic equipment, a software with a protocol for the electrodiagnostic test. You should have accessories which are used for the test, like the skin and the corneal electrodes, an instruction manual which guides you through the procedure, trained ophthalmic technician who knows what test, how the test to be performed, whether the correction has to be kept, that the refractive correction has to be kept before the eye for recording or not. So the ophthalmic technician has to be really trained. Okay. And then the patient preparation, because the patient preparation varies if you are doing an ERG, a VEP, or an EOG. So the ISF standard of ERG protocols are used in all the electrodiagnostic equipments which we use. A standard protocol for the each test, where to fix the electrodes and other requirements like the dark adaptation time, the distance from the simulator, and the optical correction, whether to be incorporated or not, is given in the manual. Okay, we have to follow the protocol. We can read it through and do it. Then the next important step in the patient preparation is, after you have attached the electrode, is the impedance check. Okay, impedances check is basically the flow of ions. Higher the noise or higher the impedance, you will get higher the noise. Okay, both are proportionally related. So the impedance should be very less to have better responses. The ideal impedance is less than 5 kilo ohms. Okay, and then the procedure is performed. Then you do the measurements and you mark the readings. The marking of the readings means you mark the negative troughs, the positive peaks, and then, like how Priya and Aarthy had explained, you identify where your P100 is, P200 is, N95 is, N75 is, to understand what is the pathology, whether there is a time delay or not. Then comes the analysis and the reporting part. Okay, so the ERG room should not be anywhere close to the lifts or generators or the electrical supply of the hospital building. Okay, because they will cause the electrical interferences and we will not be able to record ERG. Patient can be comfortably seated in the dark adapted area, and you can dilate and close the patient's eye with a cloth or an occluder. Okay, and walls of the room better to be painted in black to avoid the reflections. You should also take care that if sunlight is coming into the room, cover it with very thick screens to avoid unwanted light entering into the room. Okay, you can have red lights in your room for the electrode placements in the dark adapted states, few chairs, storage cabinets, and an area to hang the electrodes. A wash basin in the room is required for cleaning of the skin EEG electrodes after use. A dedicated grounding is required for the ERG room. Okay, this should be as less as possible so that we are able to record responses very well. Proper grounding during the ERG exam minimizes disturbances and unwanted electrical interferences. So this is the instrumentation of the ERG. So here you're seeing the simulators. Okay, this machine is from Diagnosis, which is from US. Okay, the machine showed by Aarthy was another equipment called the Roland equipment, which is from Germany. So you can have one stimulator or multiple stimulators. So here I'm showing you one big Gansfield stimulator over here, where you can record the examination of an ERG binocularly. You also have a small handheld stimulator. Okay, this is called the color burst, which is a handheld instrument which can be held very close to the eye, and you can get monocular recordings very comfortably in children. This is the power supply for the machine. Then you have a computer monitor, which has the inbuilt software to run the protocols of your ERG. So this stimulator and this stimulator basically give a flash of a light. Okay, so we can use in patients for when we are doing a full-field ERG or a flash VP, these stimulators can be used. But we need a pattern stimulator too. Okay, to run the multifocal ERG, a pattern VEP, and a pattern ERG. So as the name suggests, you need a monitor which can generate all these responses so that you are able to go ahead with the examination. Okay, so this is the machine which I told you. It's called Diagnosis, which is a worldwide leading provider for the of the human and the animal electrophysiological solutions. Okay, so the main part of your machine or instrumentation for an ERG would be a big Gansfield, a computer monitor with the software, a pattern generator, and if you are a pediatric person and you do record children's VPs and things like that, you would need a handheld device. Okay. So this is how an electrodiagnostics lab is set up, where you have all the stimulators and you have an amplifier and a pattern stimulator placed over here. This chin rest which you're seeing is used in cases with multifocal ERG, where the patient is asked to keep the chin over here and the recording happens at 30 centimeters. Okay. So you also have to follow an instruction manual. You need to have a test summary as a reference at your desktop. Okay, and follow the ISF standards. The ICAT practitioner should know to perform the electrodiagnostic test, and each lab should have its own independent normal values, which are age matched. Okay, with the electrodes they use, whether they are using say a Barian Allen electrode or they're using a DTL electrode or a Zeri electrode. So there are many things which we look into an ERG system before we buy a machine. We see that it's user friendly. It has all the protocols which are there with the ISF standards on it. And the ERG machine should help us to add on the special protocols which are required. I'm sorry. Okay, like the S-cone ERGs, on-off ERGs, or dark adapted red flash ERGs. These ERGs are special ERGs, and these are additional. These are called the extended protocols. Okay, but the basic system, you should be able to perform all these examinations. Your instrumentation which you're buying, it should be compatible. Okay, with your gold cup electrodes, silver cup electrodes, or the active corneal electrodes. So you should have freedom to use any electrode which you want for the corneal electrodes, like the DTL, jet electrodes, a gold foil, or a HK loop. Okay, an additional handheld stimulator should be there for pediatrics. A camera is a must, because the IR camera helps us to understand whether the patient is monitoring or not, and are we able to see the information clearly, whether the patient's eyes are open or looking straight during the examination. You need to have an automatic impedance system. The amplifier should be a biosignal amplifier with high and low pass filters. Automatic peak and trough detection tool should be there so that anybody can use the system and should be able to identify the peaks and troughs without much of an hassle. Automatic noise rejection or artifact rejection program should be inbuilt so that we are able to get very good responses. And this becomes very important in cases with multifocal ERGs. When the patient blinks, you have a lot of noise or artifacts generated. Okay, a blink artifact program should be inbuilt in your system. This is just a checklist for whatever I have told. Apart from the instrumentation over here, what else is required is you will need a skin preparation gel called the New Prep gel, a 1020 conductive paste, which helps in better conduction. Then some eye patches, tissues. Okay, so this is the overall checklist which you need to have in your lab. So coming to the electrodiagnostic test. Today we will be discussing about the full-field ERGs, pattern ERGs, and multifocal ERGs. So we all know ERG reflects the mass electrical potential which is generated by all the retinal cells in response to full field stimulation by light. So when I mean mass electrical potential here is where I am dilating the patient completely and I'm having a diffuse illumination like a Gans field to give flash of lights which can be appreciated by the photoreceptors and the response is generated. Okay, so pattern ERG. Pattern ERG reflects a central retinal function here where I assess the P50 gives us the more information of the macula and the N95 gives us more of the ganglion cell information. We also do a multifocal ERG, which is generated by the simultaneous focal retinal responses with a brief period of light. Okay, usually 40 to 55 degrees of the central retina is examined, especially the macula and the cone responses. VP helps in assessment of the visual pathway function from the macula to the occipital cortex. EOG gives us more information about the RPE and the photoreceptor layer. So the patient preparation, just ask the patient to have a hair wash and not to apply any cosmetics and not to wear any metal jewelry or ornaments. And cell phone should be kept away while the examination is done. So the skin is prepared with a New Prep gel with a 1020 conductive paste. You apply it on the areas. So depending where you're going to be attaching your active electrodes, your reference electrodes and your ground electrodes, with the help of the manual, you can identify it. And for ERG, for all types of ERG, that means full-field ERG, multifocal ERG, pattern ERG, and photonegative response ERG, the placement of the electrode is the same, okay? But the corneal electrode can change. So your ground electrode will be attached at the, say, here at the canthal, and the reference electrode is attached at the forehead. And the active electrodes at the cornea, you can either have a gold foil, a DTL, or a jet contact lens. Okay, ideally, we prefer the DTL or the gold foil because it does not come in way of the visual perception. Okay. So you can either use gold foil, DTL, or jet contact lenses. So this is how it is applied to the eye. So this is a gold foil over here. This is a DTL, which is just on the lower lid. And when the patient blinks or closes the eye, this can get, displaced. So the electrode attachment has to be very good because the impedance has to be maintained. So this is a jet contact lens electrode in place. Okay. So as I told you, cleaning is very important with the New Prep gel and a 1020 conductive paste to be attached. And once the impedance is in green, you go ahead and do an examination. Okay. So a full-field ERG. So coming to the most important ERG. So if somebody gives you a report like this, and if you have responses like this, okay, you have a mountain-like wave over here, then you have a negative wave and a positive wave, then you have these multiple wavelets and a cone response like this, that means you're dealing with a full-field ERG, okay? Full-field ERG has these 5 responses, and because it is being done in 2 phases, that is the dark adapted phase and the cone phase, you have these different responses which are generated. Okay, then you have this multifocal ERG. Multifocal ERG is basically responses like this, small wavelets which can be seen like this, which are N1, P1 waves again. And you have a display like this of the response. And transient pattern ERG, as the name suggests, pattern ERG is recorded with a pattern reversal. And the checkerboard reversal flickers between 2 Hertz to 4 Hertz to give you a response like this, okay, with N35, P50 and N95. P50 gives you more the macular information, N95 gives you the ganglion cell information. So full field ERG represents the mass response, and the response comes from the photoreceptors, especially the rods and cones, and the inner retinal layers also, that is the bipolar and the Buehler cells. The functions of the rods and cones and the inner retinal layers may be recorded separately by changing the stimulus parameter and the adaptive state of the eye. Stimulus parameter, here I mean the brightness of the flash which I'm using, and the adaptive state is the dark adaptation or the light adaptation. Okay, ideally we dark adapt so that we are able to record 100% of the rod responses, and we light adapt to get the 100% of the cone responses. Okay, so as we know, the number of rods which are there in our eyes are much higher compared to the cones. So we have around 120 million rods compared to 6 million cones. So that is why if you go ahead and do a dark adapted ERG, you will see a very good dark adapt response of more than 300 microvolt. Okay, where the cone responses will be smaller in amplitude, and they will be something like 150 to 200 microvolts. The rods are responsible for the night vision, cones are responsible for the day vision and color vision. So what happens? What is the principle behind ERG? You have a sudden illumination. Hello. So I think the principle is basically sudden illumination of the retina with the simultaneous activation of the retinal cells to generate the current. And these current generated by the retinal cells mix and then pass through the vitreous and the extracellular spaces. High RP resistance prevents summated current from passing posteriorly, and a small part of the committed current which expands through the cornea is recorded as the ERG response. I think we stop for today. We'll continue it in the next class. Okay. Thank you.
Thank you so much, ma'am. It was a very detailed presentation and we couldn't wind it up just a minute. Sorry about the interruption. We couldn't complete the class by today because we know the interpretation of ERG itself will take a complete 1 hour or more than an hour. So we are hoping you to join us for another session, part 2 of ERG interpretation along with EOG, ma'am. So we would like to have you again as a guest for our optometry series.
Right. I think Aarthy also will be a part of it. Okay, so I may cover the ERG, Aarthy will do the EOG. Okay,
Yes, ma'am.
and we will have some open question answer sessions also, and we'll open up for students to ask any questions if they have. Okay.
Sure.
Thank you.
Thank you. And I would like to thank Ms. Aarthy ma'am also for joining us. It was very detailed and very nice presentation, ma'am. We have learned so much from you both. Provided we expect you both to join us for another session also.
Sure. We will do that. Thank you.
Yeah,
Thank you very much. Thank you, ma'am.
Thank you. Thank you, everybody.
Thank you so much, everyone, for coming today. We are very sorry for the quick wrapping up of the session, but definitely we'll get in touch with you, ma'am, for a better and in-depth session more.
Sure. Sure.
Thank you.
Thank you.
Thank you,
Thank
Anshika.
you. Bye.
Thank you, ma'am. And I also thank our YouTube audience for joining us today. If you like our video, please subscribe and give a thumbs up to us.
Thank you.
Thank you all.
Thank you.